I'll also proceed to the next session, which is the treatment of MASLD, part 2. For the same, can I request Dr. Premashish Kar, Dr. Sanjay Padada, Dr. P.K. Agarwal to please chair this session.
It's a great pleasure to invite Dr. Arun Sanyal, whom I have known for over last 30 years, since my meeting him at AIMS, and it's really I feel honored to to chair a session with him because he has been the pioneer in all works related to the a metabolic associated liver disease, and in bringing out various therapies which can improve the progression of the disease to cirrhosis.
Thank you. Dr. Kar, this is indeed a great pleasure and honor for me as well. For those of you who don't know the backstory, he was a GI fellow and I was the intern at All India Institute. And we were scrambling at 4 a.m. to get all the hemoglobin results for all the GI bleeders before the early morning 7 a.m. rounds, where if you did not have the hemoglobin results, you'd be massacred. So we both carry that bond of war battle together. So now moving on, we're going to talk about incretin-based therapy. You heard about PPARs and you heard about saroglitazar particularly. And there is some histologic data. We published a small pilot with about 16 patients, and it did show histologic improvement, including some fibrosis improvement. But the main phase 2 trial should read out early next year, so we're really looking forward to that. Okay, so I just showed you my conflicts as well. So picking up where I left off on my last talk, I think we have to stop thinking about this as a pure liver disease. MASLD is part of a larger constellation of end organ diseases which occur to different degrees of severity in the same patient. If you got one, you're likely to have the other. So our goal is there's no point in fixing one disease if the other organ will kill you. So we need to try and fix all of the competing risks to life. So there are multiple competing threats from cardiovascular, liver, kidney, etc. We need to try and fix them all. And so when you think about things that actually affect all of these, it comes back to the root cause, which is excess adiposity. And one of the most effective ways of treating excess adiposity and reducing adiposity-related metaboinflammation are the glucagon-like GLP-1 receptor agonists. So where that GLP-1 or this incretin-based therapeutic landscape has moved to is shown in this slide. For a long time, we focused on intensive lifestyle therapy, knowing that only in 10 to 20% could this be accomplished with long-term success. But then there were first-generation obesity medicines, and now we're beginning to rapidly move from single agonists to single oral, dual agonist, triple agonists, and even combination therapies. So incretin-based therapies have already been shown to reduce weight, improve cardiovascular outcomes, stabilize renal function, improve glycemia, improve sleep apnea, and bodily pain. And there are large studies with thousands of patients for each and every one of these indications. And there are formal FDA approvals for incretins for each of these. So that already essentially is a win for GLP-1 receptor analogs. But now let's focus on what does it do for the liver. So first, as per my topic, what's here, then we'll talk about what's tomorrow. What is here, leading at the front end of this field, is semaglutide. Semaglutide is, as you know, a pure GLP-1 agonist, and it's taken as in an injectable form, or it can be taken orally. The drug development for NASH has been primarily with injectables. And these are the data of the ESSENCE trial, which is a phase 3 trial, where in the first 72 weeks, you establish histologic benefit, but the trial continues on to see whether the histologic benefit translates into clinical outcomes. And this shows that you have about a 63% NASH resolution without worsening of fibrosis compared to 34% in placebo. And for the fibrosis improved, you have 37% versus 22% in placebo. So both highly significant based on a pre-specified outcome measure. So when you combine that with all the other benefits of GLP-1s that are well established, then essentially this is going to become an anchor therapy going forward when you have all of the end organs involved. And when you look over here in the secondary endpoints, if you look at the combined endpoint of both resolution of steatohepatitis and improvement in fibrosis, again, a third of the patients. So the number needed to treat to get the combined benefit is 3, which is very good when you look at the number needed to treat for things like hypertension, etc., where they run into hundreds. Similarly, if you look at the mean change from baseline in body weight, you can see about an 11% improvement in body weight. And then, of course, you are also seeing improvement in bodily pain. But these were sequentially tested in this trial. So the primary 2 MASH resolution fibrosis first, followed, if you met those, then you move to combined endpoint. If you met that, then you move to change in body weight. If you met that endpoint, then you move to the last. So it is essentially what's called alpha recycling, where your p-value, you can use the p-value of 0.05 again and again and again. Because if you were to look at 5 endpoints simultaneously, then you would have to have a p-value. Every time you would have to divide the p-value of 0.05 by half. So then you would need to have 0.0000 p-value for the last endpoint. So here you can recycle the endpoint, and that's a valid way of doing clinical trials. This is accompanied by improvement in liver enzymes. No surprises over here, beautiful decrease in all the liver enzymes. And when you look at the NITs, you can see there is an improvement in liver stiffness measurement in the ELF. And this is occurring within the first 6 months. You are seeing a pretty dramatic drop, and there's improvement in PRO-C3 as well. So early improvement in liver stiffness, you could argue, could be due to improvement in inflammation. Long-term could be due to fibrosis. But bottom line is it does improve, and it does correlate with histologic improvement. When we look at the cardiovascular risk factors, what we are seeing over here is that the systolic blood pressure decreased significantly, diastolic blood pressure decreased significantly, A1C decreased significantly, on top of whatever background therapy they were getting. The C-reactive protein decreased significantly. The total cholesterol didn't really meet statistical significance. Triglycerides improve. LDL cholesterol did not improve. So this is something to remember. GLP-1 alone does not improve LDL cholesterol, okay? And the reason this will be relevant will come later. And HDL cholesterol also improved. When you look at the adverse events, in these clinical trials, every time you sneeze, it gets reported as an adverse event. So it's very common to see adverse events of 80–90%. So no surprise here. Semaglutide 2.4 milligram, 86%, but placebo was also 79.7%. Importantly, there were 3 versus 6 fatal adverse events, but none of these really liver-related. Serious adverse events, 107 versus 53. And AEs leading to discontinuation, 2.6% versus 3.3%. So actually, most of the patients were able to continue, and at the end of 72 weeks, 86% of the patients were still on study drug. But part of it was because there was a very slow ramp up, and when the study basically allowed people to ramp down as well to their best tolerated dose. Okay. Unfortunately, when you go into the cirrhotic population, at least based on histology, the clinical trial that was done did not show histologic benefit. Now, this study has been criticized. I was one of the co-authors of this, and we ourselves sort of later on criticized ourselves. Too small, not long enough, and because we all have anecdotal experience in some patients where GLP-1s have worked wonderfully. But I think given that this is a negative trial, given that GLP-1s cause weight loss, which in a cirrhotic patient may be particularly relevant if they have underlying sarcopenia, it might tip them into decompensation. So I think there's more work to be done for the cirrhotic population. So that's what's available. These drugs are available in India. They're available all over the world now, increasingly. But what's coming? So first are the GLP-GIP co-agonists. And this also is now, I guess, coming into India, which is tirzepatide. And now, again, GLP has no receptors in the liver, nor does GIP. So they're all working outside of the liver, mainly in adipose tissue, and increases adipose tissue fat oxidation and reduces adipose tissue inflammation. So it makes the adipose tissue more healthy. And by making the adipose tissue more healthy, it makes it more insulin sensitive. It is not releasing as many free fatty acids, and so there's less free fatty acid load to the liver, so that's how it's supposed to work. So in phase 2, tirzepatide dramatically improved MASH resolution, you can see on the left, and then on the right, you're seeing proportion with fibrosis improvement. Now going to GLP glucagon. So glucagon directly targets the liver. Now you're having GLP plus you're adding glucagon. And so basically when you do that, it increases both glucose, a little bit of gluconeogenesis, but it also increases FGF21 and bile acid production in the liver. It increases triglyceride lipolysis and decreases de novo lipogenesis, improves LDL receptor activity. So it's very important when you think of GLP glucagon co-agonists, how much GLP agonism and how much glucagon agonism there is. If you're very heavy on glucagon, you're going to get hyperglycemia. It will nullify your benefits of the GLP-1. If you're too low, it may not be enough. So is this balance? Just because two molecules are GLP glucagon doesn't mean they are the same, okay? So survodutide is sort of an optimized, probably best in class with an 8-to-1 ratio of GLP versus glucagon co-agonism. And here you're seeing per protocol almost 80%, 83% MASH resolution, and you're seeing about 50% fibrosis benefit compared to 20% in placebo. So both significant, and this is now in phase 3. It's a worldwide study. I don't know whether India is a site or not. But okay, so this is really, I think, a very, very exciting molecule. Cotadutide is another molecule. It has finished phase 2. These were the data that we published in CGH last year showing improvement in hepatic fat fraction. The histology study has been completed. We will present that at ASLD. It's an oral. I'm not allowed to present that data now, but we are going to have to wait till ASLD. Pemvidutide was presented a couple of years ago, and it's another GLP glucagon, but here it's a little more glucagon heavy. So while it showed the histologic the fat reduction in liver fat, you lost the glycemic benefit. And that's, of course, a problem in this particular population where many of our patients are pre-diabetic or overtly diabetic. So what's to come? There's a phase 2b trial with a triple agonist. This is from a Korean company called Hanmi, and this is an ongoing trial right now. And so this should read out probably late next year, if I'm not mistaken. The other very exciting molecule is retatrutide, which is a triple agonist, GLP, GIP, glucagon. And essentially, it produces weight loss and wipes out steatosis in early phases of the disease. So first of all, it produces, within 1 year, up to 24% weight loss. So it's the first time we have a GLP-based therapy which is actually beating bariatrics for weight loss. And on the right, you see at 6 months, 86%, and at 1 year, 93% patients have no more detectable fat. in the liver. So of course, this is very, very exciting. And now it is also going into phase 3 trial. It's one of the few molecules that's been allowed to go straight from this phase that Dr. Rinella and I'll be leading. So this should be starting soon. And the oral GLPs are coming. These are data for orforglipron, which we presented last year at the European meeting and showed that it produces improvement in liver enzymes. Still very early. There's a whole slew of oral GLPs that are in the pipeline from different companies. And so I think this is going to be a very, very exciting field. There's many, many companies that are making more potent GLP and GLP glucagon, GLP, GIP, and triple agonists. So the role of incretin therapies, I think, are mainly going to be at the base, where diabetologists are going to use GLP-1s in patients who have metabolic syndrome, who may have fatty liver but don't have advanced significant fibrosis, and wipe out, and with the potential of wiping out the fatty liver in its very early stages. And what will be very interesting to see is whether the number of people coming with more advanced disease decreases with that. Those who have started scarring down, I think this is going to become anchor therapy, particularly if you have a lot of additional risk factors. But if you have a lot of cardiovascular risk factors and you want to get LDL down, saroglitazar would be a nice combination with it, because saroglitazar beautifully brings down LDL cholesterol and small dense LDL cholesterol, which statins do not actually affect. The cirrhosis is where I think we still have work to do, because a small early phase trial did not show regression, but even though it was safe. So I think this is where more work needs to be done. So I'll stop by saying here are the key takeaways. GLP-1 receptor agonists promote weight loss, can improve steatohepatitis and fibrosis, although they have not yet been shown to be beneficial in cirrhosis. For GLP, these are likely to become anchor therapies for MASH with clinically significant fibrosis, especially with significant metabolic comorbidities and disease. And dual and triple agonists are probably going to be the way of the future. I'll stop over here. Thank you very much.
Now I invite the next speaker. Next speaker is Dr. Mary Renila. He's Professor of Medicine, Director, Metabolic and Steatotic Liver Clinic, University of Chicago, Pritzker School of Medicine, Chicago, US. Over to Dr. Renila.
Thank you very much. So I would agree definitely with Arun that the GLP-1 based therapies are going to be the anchor. And today I'm going to talk to you a little bit about the THR beta agonists and the treatment of MASH and how they may fit into the full landscape. These are my disclosures. So just starting with just some basics on just thyroid hormone metabolism. So as you know, the active form of thyroid hormone is going to be T3, which is going to affect all of the gene transcription down the road. DIO1 is what will take T4 to T3 and then activate transcription. DIO3 will revert to reverse T3, which is inactive. Now, it's important to understand that there are two basic receptors of thyroid hormone. There's alpha, which is present fairly ubiquitously, but primarily bone, muscle, heart, brain, and then THR beta, which is what these drugs are specifically focusing on. And these are really primarily located in the liver, a little bit in the brain and in the adipose tissue. So just as a general concept, hypothyroidism, this is actually just a meta-analysis of 13 studies, 13 observational studies, and you can see that there does seem to be tracking between hypothyroidism and the presence of MASH, both overt and subclinical hypothyroidism. And so both are put people at higher risk for MASLD, or I should say that they can manifest with increased fat in the liver. So the rationale for liver selective THR beta activation in MASLD is the following. So in a healthy liver, there's preferential DIO1, which leads to the typical activation. In MASLD, there's a reduction in DIO1 and an increase in DIO3, so you end up with more reverse T3, and therefore reduced hepatic T3 availability. And that can then result in a reduction in fat oxidation, a decrease in mitochondrial activity, cholesterol clearance, and then this, of course, results in increased hepatic triglyceride accumulation. So just generally how these drugs can work. When you have activation of THR beta within the liver, you have several things. You have increased increased beta oxidation, rather. You also have there's an increase in mitochondrial biogenesis and mitophagy that occurs, so you have increased ability to further oxidize fat in the liver. Oops, sorry about that. So there's also downstream effects, of course, with decreased inflammatory signaling, which then lead to reduction in activation of stellate cells, and that's thought to be the primary reason why you see an improvement in fibrosis in the clinical studies and basic studies that have been done. So with respect to the anti-inflammatory and anti-fibrotic activity, this is just going to summarize it. There's some, actually not a copious amount, but there's a fair amount of animal data. And just in summary, with respect to the anti-inflammatory effects, there are data showing reduction in NLRP3 inflammasome, ASC1, caspase-1, TLR4, mRNA in thyroid hormone-treated mice. Resmetirom restores RG55 and suppresses phospho-STAT3 and phospho-NF-kappa B. So with respect to direct anti-fibrotic activity, this is a little bit more controversial, but there are primarily stellate cell studies that have demonstrated a reduction in downstream fibrotic signaling. So with respect to the thyromimetics, to the left you can see just thyroid hormone, T3, which bind to both THR beta and THR alpha. Then there's the prodrugs such as the Viking compound VK2806, and this also will bind, but preferentially to THR beta. And then there's synthetic analogs or active metabolites of the prodrug, which would be the active metabolite of the prodrug would be the Viking compound, and then resmetirom is a synthetic analog, which you can see here. And these also bind specifically, or resmetirom binds specifically to THR beta preferentially. So this is just a summary. I don't think it's really meant to, I don't really mean to go through this in detail, but just to show you that there are several drugs at various stages in development. At the top, you can see resmetirom, which is approved conditionally for the FDA in the United States and imminently in Europe for the treatment of stage 2 fibrosis MASH, non-cirrhotic MASH, I should say. And this phase 3 trial interim results were finished, and that's the basis for which this drug was approved conditionally. The cirrhosis trial is also is ongoing, and I won't be really presenting any of that. We don't have the results of the outcomes data yet. The Viking compound, which is in through phase 2B, and then the others are 2A and preclinical. There are differences in potency and selectivity for beta, for the THR beta. So just to briefly go through the resmetirom phase 3 Maestro-NASH trial, which is what the phase 3 trial I was telling you about that got the drug accelerated approval. This trial population was a very metabolically enriched population with greater than or equal to 3 cardiometabolic risk factors, the usual inclusion criteria that we see in MASH trials with 52 weeks of treatment. There were 2 primary endpoints for the Subpart H approval, and that was MASH resolution and fibrosis improvement. And then the ultimate outcome, of course, is going to be reduction in liver-related outcomes and all-cause mortality, which we are anticipating in the next couple of years. I think important to note here, just quickly, the baseline characteristics. This is fairly typical. About 65% had diabetes. This is where it becomes a bit less typical. The GLP-1 use in this trial was only 12 to 15%. Now we're seeing much higher rates of dual GLP-1 use in our clinical trials, and with an enrichment in stage 3 fibrosis, which is, again, fairly typical. So as far as overall results, there was statistically significant reduction in fibrosis compared to placebo, with a treatment effect delta of about 12%, and MASH resolution treatment effect delta of about 20%, both statistically significant. No impact on glycemic control, and a reduction in LDL, and this is expected because the drug was originally developed as a lipid-lowering agent. I think it's important to note that in addition to reduction in LDL and ApoB and triglycerides, it actually reduces lipoprotein A, which is not something that is typically seen with statins, for example. With respect to adverse events, this is something that is important to note because as we start to use the drug, at least in the United States, we've been using it for just over a year. Diarrhea by far and away is the most common. The next would be nausea. Here in the trial, it was about the same. I would say in my practice, I see more diarrhea than I see nausea. And I think there at least a theory on why this might be is related to the way that the drug works. So if you have increased LDL receptor, increased intracellular cholesterol, at least initially, you have more shuttling towards the production of bile acids, which of course a lot of it will go through enterohepatic circulation, but some does land in the colon, and I think that this is mostly like a bile acid type diarrhea. So as far as patient selection, we are recommending non-invasive modalities to be able to select patients for treatment. This was, the FDA label did not include liver biopsy, which is great. So in this particular schema, we give basic parameters for how to identify people who are more likely to have stage 2 or 3 fibrosis and not have cirrhosis. So for every, the green and the orange, you notice that there's always a caveat of there can't be any suggestion or evidence of portal hypertension. Why? Because if there's significant portal hypertension, drug concentrations are much higher, and we don't have the safety data yet to have that, to give that to patients with cirrhosis, particularly advanced cirrhosis. Follow-up, Mina touched on this already. We don't have as much confidence in assessing disease improvement using non-invasive tests at this point, but we do recommend waiting a year to assess for efficacy. So I'm going to touch briefly on combination therapies and how we might be using these in the future as we start to see more drugs approved. So I'm going to start with the combination of THR-beta agonism with FXR agonism. Why? Primarily because it's been studied and recently published, but conceptually, there are reasons why we think it may be useful. You have increased reduction in oxidative stress, perhaps reduction in stellate cell activation by mechanisms that are different. But I will say that it would be, and it would perhaps attenuate the dyslipidemia that you get with an FXR agonist. But I think that this is really, remains to really be proven, specifically the effects on histology and PDFF. Here's an example. This is the DUET study, study published fairly recently. This is a phase 2A study looking at the TERN-501, which is a THR-beta agonist, and an FXR agonist, which is the TERN-101 in combination or alone. And you can see this is the study design, short study, 12 weeks with PDFF as the primary endpoint. So here you can see that there really wasn't much of a benefit at all with respect to combination. So all the way to the right in the purple, you can see the combination of the 501 6 milligrams with the FXR compared to TERN-501 in the dark blue. Really no difference. There was a statistically significant difference in corrected T1, suggesting maybe there's an inflammatory benefit, but the numbers are very small, and I think this really remains to be shown. So what about THR beta agonism and incretin-based therapy? So this is something that I think we are already seeing because patients are already on GLP-1, are already on GLP-1 based therapies, sometimes when we start them on THR beta drugs. So there are multiple reasons why these may synergize or certainly lead to augmented response, but this is, again, not been shown in the subgroup of patients who received GLP-1s, that 13 or 14% or so in the Maestro-NASH trial. There really wasn't a huge difference either way. But we do know that there is a little bit of a increased response in people who lose more than 5% body weight. So preclinical and early clinical data do suggest that there may be some synergy, though, on weight loss, which is kind of interesting, and potential for enhancement in cardiometabolic benefits. So this is a murine study. This is a humanized GLP-1 receptor mouse, or who has humanized GLP receptor, given TERN-501, which is the THR beta, with orforglipron both at low and high dose. And you can see in the purple all the way to the right, the combination of the THR beta with orforglipron. There's a significant reduction in body weight compared to the GLP alone. Here you see a similar study. Again, this is also animal data looking at the combination of either tirzepatide or semaglutide with another THR beta agonist, and you can see that there's an augmentation in body weight loss. So interestingly, this weight loss may be largely in the fat component. So as we know, GLP-1 based therapies lead, just like any weight loss, can lead to reduction in lean body mass. In fact, it usually does. About 25% of that weight loss is muscle. But here you can see it seemingly that there's a stability of lean muscle mass with a continued reduction of body fat loss. So FGF21s, which we're going to hear about in the next presentation, there are many reasons to think that this could potentially be an interesting combination, perhaps augmentation of the antifibrotic benefit, and perhaps an further improvement in cardiometabolic risk profile. And then FASN inhibitors, I'm going to just touch on this very briefly. There's a reason to believe that there could be reduced activation in stellate cells with the combination. They both seem to potentially do that on their own and with a positive effect on lipid profile. However, this has not been shown clinically, and this is a preclinical study that really didn't show, they just didn't show fibrosis. So I'm making a presumption that there wasn't an effect. There was a reduction in components of the NAFLD activity score. So DGAT2s are also, there are several in development, and there are potential reasons why this could potentially be a useful combination, possibly increasing reduction in lipid accumulation, possibly augmenting the fibrosis benefit. So as far as key takeaways, I think there's compelling evidence that linking hypothyroidism to MASLD and MASH, there's clear evidence of positive impact of THR beta agonism on liver histology. Combination with GLP-1 based therapies may augment weight loss, and I think are an exciting avenue of that we're going to learn more about in the coming years. The most common AEs are gastrointestinal, mainly diarrhea, and I think this may be related to increased delivery of bile salts to the large intestine. And the potential combinations may augment this reduction in fibrosis, which will hopefully translate to outcomes. And with that, I'd like to thank you for your attention, and I'm looking forward to the next talk. It's going to be great. Thank you.
Nice talk.
As Dr. Mary has already touched about the FGF, now let's hear from Dr. Naga about this really the new combination or the new factor which is coming up, whether it is still in research or in the market.
Once again, great talks, Arun and Maru, as my slides come up. Okay. So these are my conflicts. This is my outline. Primarily, I'll spend time on FGF21s, given some history and number of FGF agonists there are. And finally, we'll just one slide on the FASN, which is the fatty acid synthase inhibitor, Some of the slides are courtesy Dr. Nuruddin, and I'll now be discussing about the genetic targets, PNPLA3 or HSD17B13. Basics of FGFs, fibroblast growth factors. There are paracrine, there are endocrine and intracrine, okay? So the paracrine, which are FGF1 and FGF2, they are bound to these heparin sulfate proteoglycans, so they are stuck in extracellular matrix, so they don't go anywhere else. The endocrine ones are of interest, for example, FGF19, FGF21, and FGF23. Endocrine are primarily signaling. You won't see anything about them, at least in the MASLD field. There are a number of FGFs, as I said. Highlighted are the three that I draw your attention to. The first is FGF15 and 19. These are primarily involved in the bile acid metabolism. In rats, they're produced in the ileum, but in humans, they are made by the hepatocytes. There have been trials of FGF19 in humans. Unfortunately, they have not been very effective. Dr. Ranella led some of those programs. FGF21s, and I think they're looking very promising. These are the ones that you should pay attention to. There are trials of FGF21 in India. There are, for example, AIG is recruiting as well, looking quite promising. Just one word about FGF23. FGF23 overproduction can cause rickets, nothing to do with MASLD. But the reason I bring this up is this was sort of cloned at IU, and there is a monoclonal antibody against this particular FGF23 to treat X-linked hypophosphatemic rickets. Sort of esoteric, but quite interesting. FGF21 is very pleiotropic, at least in animals. In rats and other animals, they can affect a lot of different tissues. A lot of excitement about FGF21 in addiction biology. It reduces intake of food and alcohol, but the concentrations needed are quite high. I'm just not so sure they're achieved by the doses we give to treat MASLD. Primarily, FGF21 is made by hepatocytes, but it also affects on adipose tissue, a number of other functions as well, as shown in this cartoon. I'll just quickly go through the landscape. There are first generation, there were a Lilly compound and a Pfizer compound. They were largely discontinued because of lack of efficacy and maybe some side effects. And then there are 4 FGF21s shown on your right side: efruxifermin, pegozafermin, efimosfermin, and zalfermin. Okay, tongue twisters I'll walk you through. So they are in different phases. The one that looks most exciting, most advanced is efruxifermin. It is made by Akira Pharmaceuticals. This is the compound that's in testing in India as well. And a phase 2B, both non-cirrhotic NASH as well as cirrhotic NASH are complete, and I'll share the data with you. Pegozafermin is by 89 Bio. Dr. Lumba had a paper in New England Journal. And then the Boston Pharmaceutical had this thing called efimosfermin. Interesting thing about 2 interesting things. One, it is given almost once a month. Number 2, it was recently acquired by GSK for $250 million. Zalfermin is, Novo Nordisk is promoting that with semaglutide. I've not seen any preliminary results, okay? So let me just walk you through monotherapy phase 2 programs. Efruxifermin is the one that the Harmony trial, it is most advanced. These are 2 doses, once a week, subcutaneous injection, typical patients with stage 2 or stage 3 fibrosis, and Pegozafermin is pegylated molecule with FGF21, same population. Here, either given once a week or once every 2 weeks. This is the Boston Pharmaceutical compound. This is efimosfermin. This is once every 4 weeks. And the trial for this one is 24 weeks. This is the Harmony trial. This was published are coming up in Lancet. Mazanuridin is the first author. Once again, 3 doses, 3 arms, placebo, 28 milligrams once a week or 50 milligrams once a week. And then the primary endpoint is week 24, and then the secondary endpoint is at week 96, okay? And shown here are week 24 and week 96 data. This is efruxifermin once a week, 28 milligrams or 50 milligrams. What you see here is compared to placebo, both doses have significantly higher proportion of people with fibrosis improvement by a stage without worsening of MASH. This is impressive within 6 months, right? And at week 96, this is paired where the group had biopsies at baseline as well as end of treatment. If you look at week 96, the 50 milligram dose had a 75% reduction in fibrosis at least by a stage. Impressive compared to placebo, almost about a 50 percentage point difference. Very impressive. This is phase 2B. Now it is undergoing phase 3, and Indian sites are participating in this. This is pegozafermin. This is Dr. Lumba was the first author of New England Journal paper in this, multiple doses. Bottom line, there was not a dose effect, but this is given either once a week or a higher dose every 2 weeks, has significant improvement in both NASH resolution as well as improvement in fibrosis. My understanding is this is onwards to a phase 3. This is the one I said, Boston Pharmaceutical compound, given once a month or once every 4 weeks. At 6 months, which is basically giving 6 doses of this therapy, led to significant improvement in NASH resolution as well as improvement in fibrosis. On your left is 68% of people after 6 injections once a month had a resolution of NASH without worsening in fibrosis. Nearly 50% had an improvement in fibrosis by a stage after 6 injections. Very exciting, and that's why GSK recently acquired this compound, and I think they are moving onwards to a phase 3 program. I'm going to skip this. Efruxifermin phase 2 program. This is the Symmetry trial. This came up in New England Journal not too long ago. Dr. Rinella, Dr. Nuruddin. Dr. Nuruddin was the first author of this paper. Once again, the same 2 doses, 28 milligrams or 50 milligrams, given once a week injection. These are Child's A cirrhotics. And compared to, this is the completer analysis. This is week 36. There was a signal, but this was not statistically different. Both doses had about a 22 to 24% compared to 14% fibrosis improvement in cirrhotics. This was not statistically significant at week 36. However, when the trial was continued up to week 96, you could see about a 25 percentage points higher improvement in fibrosis in NASH cirrhotics or MASH cirrhotics. This is for the first time you actually have a compound improving fibrosis in people who already have cirrhosis. Never been shown before. And even the intention to treat analysis, there's about a 20 percentage point higher in 50 milligram efruxifermin compared to placebo. So this is also onward for a cirrhosis trial. Dr. Rinella is heavily involved. So Dr. Sanyal. So NITs with efruxifermin, same direction. So it gives you confidence what you saw in histology is reliable, okay? And as a class effect, though, FGF21s have GI intolerance, nausea, diarrhea, but more importantly, though, FGF21 analogs seem to cause bone mineral density loss, about a 1 to 2% loss in bone mineral density. Some of the newer trials are paying attention to excluding people with osteoporosis as well as vitamin D supplementation. So hopefully that will take care of it. Otherwise, this bone loss is a concern with FGF21 analogs as a class. FGF21 analogs do have metabolic benefits, though not as profound as been described by Dr. Sanyal for incretins. All these improve insulin sensitivity. If you recall, FGF21s were first started both by Pfizer as well as Lilly to treat diabetes. That's where they started. Turned out they were not as potent as incretins. They improve serum lipids, and there is also some weight loss, anywhere from 2 to 5%. So this is in addition to improving NASH and improving fibrosis, there are some metabolic benefits as well. So that is encouraging to me as well. But in terms of the FGF21s compared to incretins, two things stand out in my mind. One is the rapidity of action. They work very fast. You can start seeing an effect within 6 months, even for fibrosis, certainly for in terms of fat resolution or steatohepatitis improvement. And another is the improvement in fibrosis in cirrhotics, within 96, which you did not see with incretins so far. So those two things are sort of impressive with FGF21 agonists in my mind. So to summarize, FGF21 molecules or analogs are exciting. These are something you should pay attention to. All are injectables. There are some FGF21s that are being developed for oral consumption. We just have to see how they're going to play out. We touched on efruxy, that is by Akero, pegozafermin 89 Bio, and efimosfermin, this is by GSK now, are in advanced stages, and I think you will see in next 3 to 4 years. As I said, Akero compound efruxifermin is the only one that improved fibrosis in cirrhotics. There are favorable metabolic benefits, but the bone loss is a concern. And just one last slide about the denifanstat. This is Dr. Rinella briefly touched on it. This is a fatty acid synthase inhibitor. This is given orally, and Dr. Lumba had this paper in Lancet Gastroenterology and Hepatology. After, I think this is a 52-week study, oral, this therapy improved NASH resolution as well as improvement in fibrosis. Head-to-head, I think its efficacy is comparable to that of resmetirom, ballpark. One thing very intriguing about this compound is apparently profound weight loss, and a bit downplayed in the paper, but the people who have participated in the clinical trial have said some patients could just pull their hair and it will just come out. It is in phase 3, and we are not participating in it. Dr. Sanyal might know more about this program, but this is one that's ongoing. So this is exciting just because oral compound improving both steatohepatitis as well as fibrosis. I think that concludes my talk. Yep, so just the take home is FGF21s are something you should keep an eye on, and they're certainly going to come to India for clinical trials and hopefully for clinical use as well. Thank you.
Excellent, sir. Please join, sir. So at the end of these 3 exciting talks, the house is open for the questions.
The placebo, hello. Any one of you, both of you can take this question, the clarification. Does FDA has got any absolute cutoff for the placebo response? Here we've been varying in the similar class of the drugs, right? Done in the same, almost similar cohort, the placebo responses has been quite varying. 14% with the resmetirom of course another class. In the fermins also there has been quite an amount of varying is there. So is there any FDA cutoff for an absolute this?
No, this is a very, this is a vexing issue in the design of trials for NASH because every study has a different, from as low as 5% to as high as 30% across trials, where you think you've defined the population as best as you can, that they all look the same, but clearly they're not. And there are some underlying factors that may be playing that we don't yet have a good handle on. There's some recent data which has not seen the light of day yet, that having specific alleles for 11 beta hydroxy dehydrogenase may actually impact placebo response rates. So that may account for some of the variability from trial to trial. This is Naga from the Lilly data. I just saw it last week. So it's really hot off the press at this point. But that's why we have to always look at placebo-corrected response across these trials. You don't look at the actual full response because the placebo, the groups are clearly somewhat different. So if you have to compare across trials, it's best to look at placebo-corrected response.
I agree with you. I think really it is not the placebo, it is the placebo-corrected response that I think just sort of tells the story.
My question to Dr. Renella. In this real-world clinical practice today, with the GLP-1 agonist being one of the main drugs for MASLD, where would you really place resmetirom? Which class of patients would you primarily want to start on, whether they would be lean MASLD or those without comorbidities? Unless we have more data on the combination, where would you primarily use resmetirom?
Yeah, that's a very pertinent question. So I think most patients with MASH would benefit from a GLP-1 because of their metabolic comorbidities and their risk of cardiovascular death and so on and so forth. So I think that generally, if somebody meets criteria for a GLP, I generally will start with that. I think that what would make me want to add resmetirom on top of that would be somebody who's got more advanced fibrosis. Perhaps people with very significant fibrosis are gonna need a little something extra for fibrosis. The other thing to remember with GLP-1s is that, at least based on real world data, about 50% of people are still on it after a year. So there's a fair amount of attrition on GLP-1s. And so there's that. And then the other thing is, I think this idea that you may see augmentation of weight loss with the addition of THR beta or resmetirom, I think is really interesting, because I don't know if you've noticed, but there's certainly, after a period of time, there's metabolic adaptation, and many patients stop losing weight on a GLP-1. And so I think that's an interesting, population to study to add on resmetirom, for example.
Thank you.
I think very nice talks, and I just thought I'll just give the Indian perspective. What do we stand? Because this is a future kind of therapy for us. So many centers from India were part of the SENSE trial. And I think we know that the papers have been filed to FDA, and once it gets approved, there's a possibility that we also may have SEMA with us. SEMA oral was available for us for quite some time. We have done some work on oral SEMA in MASLD, which is under publication with Sanjay is here with Department of Endocrinology. The injectable SEMA became available only 2 months back in India, for approved only for diabetes and obesity, and we're still approved, as I said, waiting approval for MASLD. For survodutide and also for pegozafermin, the approvals are still on, and in India we are going to be part of those 2 studies as well. But as far as the resmetirom is concerned, when this MASTRO-NASH happened, India was not part of that. So when the papers now were filed to the Indian authorities for resmetirom to get a direct approval, they were denied that this is what we hear, and they were actually told to do this study again because there were no Indian patients involved in the resmetirom MASTRO-NASH study. But then somehow, and then the cost was also a factor, 50,000 USD, I think, per year is roughly the cost what we hear on, resveratrol. So now what we hear now is, and now we have in India is, two or three companies, what they've done is now they're manufacturing this drug, resveratrol, generic, outside India, and they're getting India, and we have now started prescribing this drug to our patients on compassionate ground. And I don't know if you can understand, in rupees, per month cost is only 3,500 rupees for resveratrol in India. I think most of us have started using, but this is, as I said, not being manufactured in India, and it's manufactured in neighboring countries, coming to India through a legal route. The authorities are approving it, but then, as I said, since we did not have any patient in the master Nash, I think so that's the way stand. Yeah.
So can I have a, yeah, after
Yeah,
that?
yeah, mic three.
Sir,
So last
my question is for Dr. Mary. Actually, ma'am mentioned few combination therapy. Here, ma'am.
They're in front.
My question is for you mentioned few combination permutation combination for combined therapies. Like, is there any data suggestive of incretin plus PPAR, saroglitazar plus incretin based therapies? What is the study or data suggestion? What's your take?
So you're asking if the combination of GLP-1s with the PPARs, like a pan PPAR, or like a lanifibranor, for example, or a Saro, or is that what you're asking?
Yes, ma'am.
Yeah, I mean, I think it does make sense in the sense that you would see attenuation of some of the weight gain. You get a little bit of weight gain with the PPARs, not a huge amount, but with Lani, you might get maybe 3-4%, which is, can be significant. So you would attenuate that. That would make sense. You also would have some complementary mechanisms of action, reduction in lipogenesis and also reduction in oxidation, reduction in free fatty acid delivery. So it makes sense that it could be, you'd be combining an oral with an injection, but I think that it would make sense. I don't see a good reason why you wouldn't want to use it.
Ma'am, is there any study in pipeline, or
Is there what?
is there any study in pipeline, or future studies coming on, like any previous data?
I'm not aware of a combination PPAR with GLP study, but maybe, are you aware?
No, but the way I think the way you have to think about this is that what is established currently with saroglitazar is that it's very good for reducing triglyceride, it's very good for reducing LDL cholesterol and small particle LDL cholesterol, which statins cannot do. So, and there is some imaging and small data on histology showing that maybe the liver disease may be getting better as well. But by early next year, we should have much better data from the phase 2b. So incretins benefit, so you have to look at the patient in their totality. If you just look at their liver, you're not doing your job. You have to look at their cardiovascular risk, you have to look at their EGFR, you have to look at the totality of the patient. If any of those are problematic, that they have an increased cardiovascular risk or their GFR is a little bit low, then you need to have a GLP anchored therapy for all of those benefits, which, none of the other classes of drugs currently have been shown to provide.
So we'll wind
Particularly if you have increased cardiovascular risk, that's where the LDL really comes in. The saroglitazar may help you because it will actually reduce triglycerides and the LDL cholesterol and add to the benefit of the GLP. So that's where, with the current evidence, that's the best way to use that combination.
Yeah, Vijay sir.
Dr. Mohan Prasad. So to Professor Arun Sanyal, I have a question. Like 30 to 40% of these, side effects that we see with the GLP-1RA and GIP, so diarrhea, nausea, and all that. So can we, in real life practice, preemptively prevent it by some drugs that, like, you want to give, ondansetron or something like that? So just wanted to ask you that one question. And the second one is a comment. And seems to be placebo is dangerous because you see that efruxifermin trial, all the comparison, out of all serious adverse events, it was only placebo that caused one death. So I don't know, are we justified in using placebo-controlled trials? This is in the lighter vein.
So I won't respond to the second comment. I'll just respond to the first one. I think it's very important with GLPs to go slow. GI doctors and hepatologists, that's sort of a rookie mistake that endocrinologists tell us that we make, is that we try to go too fast. You have to take your time. This is a marathon. So don't increase doses at frequencies less than a month. And if you do that, 90% of patients actually can handle the drug. And I think Lilly has led this field in maximizing compliance. And in the current trials, 85 to 90% of people at the end of 72 weeks are still on active drug. So I think, and then yes, you can, to answer the specific question, you know, there are a lot of guidelines now on how to manage the GI symptoms around GLP. Something to remember is if you're going to scope the patient, you got to stop the drug, or you got to do some modifications to make sure they don't vomit while they're, when you're trying to intubate them.
Can I make one comment though? There is one incretin made by Altimmune. It's called pemvidutide. Arun had a slide on it. It does not require titration. In their phase 2b, 98% compliance. So, and that may be because their GLP is lower than the glucagon. That may be the trick there.
So, but problem with pemvidutide is you lost your glycemic benefit.
Sir, Dr. Arun, sir, one problem is that once you start the GLP-1s, do we have got any endpoint to stop them? No.
No, it's like diabetes or hypertension treatment. But that is true for all NASH therapies. So don't pick on GLP-1s. That's true for resmetirom. It's true for saroglitazar. It's true for every drug in NASH because it's a chronic condition. It's not a finite infectious disease where you treat it and then you're done after. It's not hepatitis C.
So it's ecosprin, which one has to take forever, like statins.
The GLPs have not had big signal. Now, FGF21s, there is a concern about bone health. So all the trials are monitoring, you know, bone health very closely. And patients who are low levels of vitamin D are excluded from the study. They can come back and get rescreened after they fix that. People who have osteoporosis are excluded from all of the ongoing FGF21 trials.
Thank you.
I think, you know, it has been very exciting. We have taken, sorry organizers, 3 minutes extra. So, you know, you can pardon us for that. And we conclude this session now.
Thank you.
Thank you, sir. I'll request you for the center of the stage for a group picture.